Urinary incontinence, enuresis. Enuresis is common, affecting about 8% of children at age 8 years. It is used to describe a condition in children who have no other lower urinary tract symptoms, have no history of bladder dysfunction, and yet still leak urine at night. It is categorized as primary enuresis, which is enuresis that occurs in children who have never achieved satisfactory periods of nighttime continence, which includes the majority of those diagnosed. Secondary enuresis is enuresis that develops after a dry period of at least 6 months. This normally occurs after a stressful situation such as parents divorcing or birth of a sibling, and its exact cause is not known. It is thought that heredity may play a role, as children with both parents having enuresis have a 77% chance to develop it. If one parent has enuresis, 44% of children will develop it. A single region of chromosome 13 has been identified as a specific marker for this tendency. Many mechanisms for enuresis have been proposed and include increased nighttime urine production, small bladder capacity, and deep sleep or abnormal sleep cycle. A greater urine production coupled with small bladder does not allow for much time before the bladder is sensed to be full. It is thought that when the child is soundly sleeping, the individual does not recognize or is not alert to the signal of a full bladder, so the bladder reflexively empties. It is also thought that the type of sleep the child has is of poorer quality, with sleep fragmentation being implicated. For those with sleep apnea, they have a similar deep sleep disruption pattern, which may explain enuresis in children with this disorder. When a child presents with enuresis, a urinalysis or urine culture is obtained to rule out any pathology, and if it is normal, a focused history and physical, as well as a stool and voiding diary along with fluid intake, is obtained. Results of the urinalysis have not been shown to affect the clinical management of enuresis. If no daytime incontinence is occurring, management can begin. If parents wish for a more extensive workup, a nighttime urine collection can be obtained to document excessive output. Pre- and post-weight pad weight testing, as well as collection of any voided urine, is needed for this overnight testing. A brief developmental history, response of the enuresis on the family and caregivers, and the effect the enuresis is having on the child's social network are also important. In some instances, child abuse occurs as the parents are struggling to deal with the issue. Education as to why and what this issue is occurring is vital, and the parents need to understand that this is not something the child is able to control. A more complete workup is required if daytime incontinence is present. Encopresis is defined as fecal soiling associated with functional constipation. It is fecal incontinence not caused by any organic or anatomic lesions. The constipated stool causes a distended rectum, which over time does not sense fullness, secondary to the chronic distension. The internal anal sphincter also remains open, secondary to the fecalith, which causes leakage of stool around the constipated mass. Leakage of stool may occur during the day or night. There are rarely physical causes other than a constipation. Treatment involves recognition of the problem, dietary modification, such as increased fluid and fiber, regular daily toileting, and a reward system. Some children may benefit from psychological evaluation and therapy. Reflexology and biofeedback training can also be used. Returning to enuresis, in addition to encopresis, a more thorough workup is required if there are abnormal lab results. Daytime incontinence or other lower urinary tract symptoms include poor urinary stream, which requires referral to a pediatric urologist. Excessive snoring or any signs of psychological problems need to be referred to the appropriate individual. As stated earlier, education to parents and caregivers about normal developmental milestones for continence is important. These caregivers also need to understand that the child cannot help this problem and that he or she has no control over it. Treatment recommendations need to be understood and agreed to by both caregivers and the child. Management includes lifestyle changes such as regular daytime voiding, management and prevention of constipation, and fluid restriction just prior to bedtime. Setting the alarm clock to waken the child has not been shown effective in helping the child to awake. Instead, bed alarms, two of which are pictured in the photos on this slide, can be used. There is a urine sensor attached to the child's underwear or is present in the bed pad. The portable alarm box is worn on the wrist or pajama top. Some models not only alarm, but also vibrate. The idea is that when the alarm goes off, the child will better hear the alarm, wake up, and take him or herself to the toilet. Mom and Dad need to serve as a backup when the alarm goes off, as the child may not hear the alarm. Over time, the child becomes conditioned to the feeling of bladder fullness and will wake up when this is sensed, rather than needing the alarm. Bed alarms generally cost between $48 and $70 and are generally used for children 8 years of age or older, and studies show about a 66% success rate. A prescription with the terms medical device included in the naming of it is used for reimbursement purposes. DDAVP is a synthetic analog of antidiuretic hormone, or ADH. This hormone decreases nocturnal urine production, causing the renal tubules to reabsorb rather than excrete water. It is available as a nasal spray, in melt form, or a tablet. In one study, the melt form was more effective than the tablet. The relapse rate is 90% when this drug is discontinued. Imipramine, a type of tricyclic antidepressant, has been used in the past for treatment of enuresis. Secondary to its high side effect profile, it is no longer recommended for treating enuresis. This ends our lesson on managing enuresis. Thank you for your attention.